Welcome to our presentation on factors associated with food safety behaviors in cancer patients seeking treatment. The importance of this study is because cancer incidence remains high, as does mortality, despite recent medical advances. Cancer patients are at increased risk of foodborne disease acquisition, both because of their weakened immune system from receipt of cancer treatment and because of cancer as a disease. A study by WHO and FAO indicates the relative susceptibility to listeriosis of different types of cancer compared to the general population. Food safety and food insecurity in the U.S. come together because 48 million Americans experience foodborne illness annually, and 17.6 million households in the U.S. are food insecure, which could push them to acquire food in more risky ways or consume more high-risk foods.
The objective of this study was to determine food safety knowledge, behaviors, and attitudes among cancer patients who are seeking treatment. We also assessed the effect of socio-demographic factors of these patients, including food insecurity, on food safety risks. The findings of this study will allow for clear recommendations and development of more effective strategies to reduce foodborne infections and ultimately improve health outcomes in this population. It is a cross-sectional study where we studied a population of cancer patients who were receiving some form of cancer treatment between June 2016 and August 2017. The cancer clinics participated for our study includes James Cancer Hospital, Stephanie Spielman Comprehensive Breast Center, and OSU Hospital East. There were validated questions with 173 questionnaires, and the food frequency questionnaire was also given to learn what foods patients consume over the period of treatment. All data were analyzed using SPSS software. All food safety score was graded by percentage correct based on how well the patient correctly answered the questions. The food security score was assessed by giving a point for all responses except a never. High number of points indicates increased food insecurity. The food acquisition score was also assessed in a similar manner that all answers were given 1 point except answering a never.
We found that over 60% of the participants were female, a majority of them were over the age of 50, nearly 90% were non-Hispanic white, over 60% were married, and only about a quarter of them had less than a high school degree. 38.6% of our participants had breast cancer, 15.8% had prostate cancer, 11.4% had colorectal cancer, and then 83.3% received chemotherapy, which could be administered in combination with radiation or surgery, reported at 46.4% and 32.4% respectively. For food insecurity, using this validated questionnaire, 19.1% of patients were identified to be food insecure. Broken down, this is 9.4% reporting marginal food insecurity and 9.7% reporting low or very low food security. Patients were asked about their risk perceptions using a Likert scale in which they could respond with strongly disagree to strongly agree responses. Most thought that contamination by foodborne pathogens is a serious problem, and only half were aware that they were at increased risk for foodborne infection. Most thought that they knew how to keep food safe both when eating out and when cooking at home, but as we'll see from their behaviors, this may not necessarily be the case. For their attitudes and behaviors, also assessed on Likert scales, for attitudes strongly disagree to strongly agree, and behaviors never to always, we found that there was little interest in using a meat thermometer, and this was shown also in behaviors in which very few people reported using a thermometer either to record the refrigerator temperature, determine if food was fully cooked, or determine if leftovers had been appropriately reheated. On the plus side, most reported washing their hands when preparing food and washing raw vegetables. Determining food safety knowledge was used by assessing 5 different categories of food safety knowledge questions. Each was scored on a binary scale, correct or incorrect, and then calculated using an academic scale of A to F. So we found by percentage that food storage, refrigeration, and general food safety had the lowest scores, averaging at about what we would consider a C, approximately 70%. This was then determined if food safety scores were correlated with demographic factors, and it was found that significant correlations occurred between food safety knowledge and federal food assistance program enrollment, private food assistance program enrollment, smoking frequency, and food insecurity. Food consumption and acquisition was also determined. Food consumption was a binary scale, and acquisition was another Likert scale from never to always. Almost all patients reported consuming at least one high-risk food. 84.9% cooked with other people, and approximately half removed spoiled parts from fruits and vegetables. Other risky food behaviors that were reported but were less predominant included seeking out and consuming roadkill, purchasing and eating expired food, removing rotten parts from food such as lunch meat, cheeses, molds, and grains, and eating non-food items as well as eating pet food. These were also analyzed by ANOVA for the high-risk food consumption score and determined to be influenced by demographic factors such as enrollment in federal food assistance programs, age, income, and food insecurity.
We conducted a focus group research with Evans Lab Group and Cardiff, Wales to investigate patients' preferences in formulating food safety interactive educational tool. We asked the patients for visual and stylistic preferences like colors, graphs, and pictures, and also clarified content preferences. While majority of cancer patients were aware of the risk of foodborne illness is a serious problem, they were not aware of themselves belonging into higher risk group. Proper education to this high-risk population is vital to decrease the risk of acquiring foodborne illnesses and to maximize the efficiency and the outcome of cancer treatment. Study findings can be used to develop effective food safety education programs and highlight the need for food safety education of patients during cancer treatment. These quantitative data and qualitative data collected by Evans' research group are being combined to develop a specific 15-minute digital food safety education module for cancer patients. This information can be also used by healthcare providers to prevent foodborne infections among general and low food security cancer patients. We'd like to give our special thanks to Dr. Hatsu, Dr. Diaz-Pardo, Dr. Bott, Dr. Illich, Dr. Lusberg, Dr. Grenade, and last but not least, Ms. Kane, Ms. Beery for being part of our study. Thank you for your time, and we hope you had an informational session through our presentations.